atop the Aubrey Plaza in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians. I'm Matt Gotthold.
And I'm Rob Walter. Check us out on iTunes, Spotify, YouTube, and a whole bunch of other places, as well as podcastpediatricians.com. And again, another brand new Podcast Pediatrician episode. And spring is here.
It's in the
Matt's
air.
pining for Vermont. When are you going back to Vermont?
June is the earliest I know because Justin, my son, has a little time off from medical school, and he wanted to go up there with my wife and I.
Oh, nice. That's nice. Yes, at PCOM.
Yes.
When is he going to come into my practice? I know he's not going to join your practice. I'll
You
save
may be
a
right
spot
about
for-
that. First, I have to convince him about pediatrics. You know.
Oh, I know. He'd be so good. He'd be
Right
so
now,
good.
he's just trying to keep his head down and understand all the microbiology that we understand just enough to practice, but he has to do it in detail, right? So.
Right. And I a little closer, so I like to go to the Jersey Shore, and I have to crow a little bit for a Jewish boy from Long Island. I was there this weekend. I replaced the screens. I learned what spline is. Thank you,
Wow.
Young. I oiled my teak furniture.
How about
I
you?
painted multiple dressers with Scuff X. Got a new washer and dishwasher. You know what I learned? This is my wife said, "Don't say this
Yes.
out loud," but I'm going to say it first. I never knew. I'm almost 65. I never knew what jet dry was, a liquid you put in a dishwasher. I've had probably 12 places that have dishwashers. And I'm like, is that new? And we're looking up, it's been since the 70s. And she's like, what do you think when that light goes on? And I think, oh, it's working.
Yes.
Like there's a light. And all my, all my glasses are spotty. So did you know about jet dry?
No.
You didn't?
No.
Oh, good. Okay.
I think
It's
what we
liquid you put in the
use-
dishwasher
yeah,
specifically?
All
right.
The current thing we use, is it leaves the spots off for
No,
the most
so-
part, but
so
jet dry.
I really think
Gotcha.
you and I are the only two people of this age who didn't know that existed.
That may very well be.
I'm so happy to
Knowing
tell
both
people
of us,
that.
yes.
It's so embarrassing. Book club. We
Yes.
both loved Hamnet.
I thought that was one of the best books I've ever
Oh my
read
gosh.
in my life.
And so did I. But again, one of our fellow people who doesn't love
the
feelings.
same curmudgeon.
Didn't love it. And we both cheated on book club for the first time. We both listened to the Audible one.
I always cheat.
But it was Jessie Buckley.
Yes.
I never cheat. Jessie Buckley, who won the Oscar
Yes.
for the movie.
I'm not
her
sure I
voice
would
was
have
so
enjoyed
good.
it to the same extent without that narration.
I'm not sure either.
Yeah.
The whole part about when
Yes.
spoiler alert, when someone
Yes.
dies.
Yes.
It was just I was like crying in my car listening.
It was heartbreaking.
It was.
And when something breaks your heart to the extent where you feel the tears welling up, and it's a fictional character, right?
Right.
That's real good.
It's really good. Then you remember I was listening to something else they were talking about the human experience. Most time, for human experience, the good old days, half your kids died, right? Like everybody was dying all the
Yes.
time. So
Yes.
anyway, we don't realize how lucky we are to be at this time.
This is true.
And then you went to spring training. I'm
did.
so jealous.
Yeah, so I glommed onto my brother and his two best buddies, one of whom used to be high up in the Phillies, and the other of whom has a place down in that area. And so it was a pretty reasonable trip, and we got to see a couple games. We saw, check this out. So we went to the Phillies-Yankees game. It was at the Yankees spring training stadium, like Steinbrenner.
Right.
And a Yankees fan held the door for me,
Wow.
even though I had a Phillies hat on.
And did he shut it in your face?
No. I think he had a look at it and don't do that again or something. I don't know.
I'm just saying a Met fan would not have done that.
No.
And then I was kind of so pissed off at the Phillies that they let go of Harrison Bader.
Yeah,
I thought he was such
I thought
a great
he was
fit.
solid.
And Ranger, who
Yeah,
won the World
that
Baseball
one
Championship.
broke my heart a little bit.
But this guy Justin Crawford, who's like Carl Crawford's son,
Yes.
who's so fast,
Yeah.
and he's ninth, and then we have Trey Turner first, the two fastest guys in the
Yes.
bases.
Yes.
And we'll see if Aaron Nola,
Hopefully that'll translate.
if Zach Wheeler can come back.
Yes.
But there is hope.
We will
Hope
see.
eternal. All right, so Maddie, let's get back to some interesting papers in last year, but I guess it's my turn to do the disclaimer. We
bet.
are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care. All right, Maddie, hit us with moisturizing.
All right, so we're just going to do a couple kind of mini shots here. So the first paper is on emollients and their help in preventing pediatric eczema, and this was a randomized clinical trial by Simpson et al., JAMA Dermatology, July of 2025. And so what these studies revealed was that it was a randomized controlled study on infants less than 9 weeks. Daily full body emolliation. I guess that's a word. No, emolliation means something else, doesn't it? Let's not say that. The use of emollients,
Yes, full
body emollients
on children.
At 24 months. They found that there were 23% less troublesome atopic dermatitis.
Right. So starting it at 2 months of age, full body every day can prevent later eczema. And that was first said in a study in 2021, but then a Cochrane review said, nope, it's not effective. And then another study last year said it may not only prevent eczema, but prevent the atopic march of asthma and allergic rhinitis. So this is big. I think this is something that for primary care we should think about being more strong about, saying, hey, especially if there's a family history and they're kind of dry initially, moisturize them. Once or twice a day.
Lube them up.
But then there's the dog thing.
Yeah, the dog thing's fascinating. And but it goes the whole this whole random proteins affecting the future of your children, whether they be gut-wise or whether it be topically, all these things, right? So what Rob was alluding to was that the other really astounding aspect of the study was that it showed that in addition to the other benefits of the daily emollient use, if you owned a dog, there was even 29% more improvement over the fact that your child would go on and develop long-term issues with their skin, atopic dermatitis. In many studies, pet ownership from birth reduces atopic dermatitis. So the big takeaway here, moisturize daily from as young as 1 month old, especially if the child's at high risk, and buy a dog. Right? And fewer baths, are oftentimes a piece of this as well.
Right. But as we all talk about, if you already have terrible allergies, you're older, maybe don't buy a dog.
Yeah.
And I would say, because I'm a dog person more, I'm not sure cats will do it. But they are more allergenic. But maybe getting a cat from the get-go might be helpful too. But
who knows?
Let's go with dogs.
All right. So next paper deals with teaching sign language to deaf children at a young age.
This is actually not a study. It was a essay written in Pediatrics in February 2026 from a Dr. Megan Pesh, who is out of University of Michigan, and she's a developmental pediatrician, and it was titled Embracing Bilingualism for Children Who Are Deaf and Hard of Hearing. And again, her daughter has cochlear implants for severe hearing impairment, and we know that these implants do not cure deafness or restore typical hearing, and in the best case scenario, they're still going to be somewhat behind their peers in language and reading. She mentioned, I wasn't aware of all this, that for these children, it has always been encouraged, and she was encouraged, to wait and see on starting American Sign Language. See if she really needs it. We're trying to prevent language deprivation syndrome or permanent brain alterations. And oral-based deaf schools rarely teach American Sign Language. I used to live near Gallaudet and be around a lot of people who are signing, and they all knew how to sign, but now the approach seems to be, if you're getting these cochlear implants, maybe just try for oral. Don't confuse them by adding sign language in them. But the data shows in many studies that rather hindering speech if you do American Sign Language earlier, using it early actually supports spoken language development and bilingualism. Inclusion of ASL along with spoken and written language supports promote cognitive growth, emotional security, and developmental literary skills. So it's not, will this child speak? What do we do to make this child speak? It should be, how do we ensure that this child with profound hearing issues thrive? And my takeaway was, we should promote bilingualism from the get-go. If we have these patients, and we both do, we've got cochlear implants, that we should be asking, hey, are they learning American Sign Language? Are you learning it? Not that we're saying we don't think they'll hear and we don't support trying to make them talk, but this can help with learning how to talk to make sure that they don't have this language deprivation syndrome. And I never really thought of it that way. How about you?
No, I think that this is a brand new take on what has always been a presumption. And like so many other things that we deal with in the scientific community, like, hey, sometimes you have to look at it from a different angle to see really what is most beneficial for the patient.
All right. The final paper is about universal cholesterol screening. And Maddie, give us the background about that.
Okay, so the background on this, and I have to admit from the get-go that I have always struggled with trying to justify doing this for a lot of different reasons. But the background on this is that in 2011, the Academy of Pediatrics recommended universal cholesterol screening for children, first at 9 to 11 years old, so sometime within the span of those routine visits, and then again at 17 to 21 years old. But USP-STF says evidence is insufficient and recommend instead a selective screening for high-risk individuals.
So they were not on board with this, the
Exactly.
PSTF.
Yes. And so Rob and I both attended a Hot Topics conference back in 2018 where we had two prominent pediatric cardiologists actually debate this topic.
Right, Dr. Dadlani and Zapala. They both supported this thing, but they made the debate about the argument. It was fun.
Yeah. So the main goal of this universal screening is to identify heterozygous familial hypercholesterolemia, and that's a mouthful. And despite the mouthful, it occurs about 0.3 to 0.4% of the time in human beings. But it has pretty serious implications. Early myocardial infarctions, death oftentimes in somebody's 30s and 40s. And we know at this juncture that statins are safe and effective starting at, as young as at 10 years of age. And cardiologists are the main proponents, in most cases, of this universal cholesterol screening. But skeptics say only if the benefit outweighs the risk and it's cost effective. Plus, there are unknown effects of a lifetime worth of taking statins. Normal lipids can give a false sense of security as well. So it's impossible to do large randomized clinical trials comparing screening versus not, or different screening strategies measuring outcomes over 5 to 6 decades, at least at this point in our scientific community. Alternative to this is to construct an in silico model that stimulates the long-term benefits, risks, and costs of lipid screening decisions.
And remember what they do in Europe, which is not what they don't do universal screening. They do a cascade approach, looking for that 0.3 or 0.4% high risk of familial hypercholesterolemia, where they just screen with ALDL and genetic screening of first-degree relatives of anybody with FH, and continue cascade screening with any new cases identified. Another approach to look for this small group of humans that have this would maybe add also doing newborn screening, looking for that familial hypercholesterolemia genetic variant. But screening newborns for adult conditions is controversial. We talked about the Baby Seq program years ago where they're doing whole exome sequencing. So other people say it would be more cost effective just to look for relatives of people who have the condition or screen them at birth. So the paper that came out was called Familial Hypercholesterolemia Screening in Childhood and Early Adulthood, a cost-effectiveness study by Bellows et al. In JAMA in January of 2026.
So the premise was that standard cost-effective threshold is $100,000 in terms of quality and adjusted life years gained when this is treated. So any screening strategy should cost less than that. Using a CVD positive model, a validated simulation of cardiovascular disease risk factor management and outcomes, and this essentially simulated lifetime health and economic outcomes for a hypothetical cohort of 4.2 million U.S. 10-year-olds of universal screening versus usual care. 6 scenarios of universal lipid testing. 10 years old, 18 years old, each 3 separate LDL thresholds for genetic familial hypercholesterolemia testing. And the strategy was for greater than 130 LDL or greater than 160 LDL or greater than 190 LDL.
Right. So 6 categories, looking if they should do the genetic testing if you hit 130 or 160 or 190 for 10 and 18-year-olds. So they looked at all 3 of those, looked at the cost effectiveness, and guess what? None were cost effective at all compared to the current status quo of lipid testing, often in adults over 30 years old. The best of the 6 were screening 18-year-olds only and treating those with an LDL greater than 190. But that would still cost more than $300,000 per quality-adjusted life year gained. This was not foreseen by those who originally advocated for universal screening. And an editorial with this paper from Dr. Matt Gilman of the NIH states that this new evidence allows pediatric caregivers to be confident if they decide not to perform universal lipid screening among their patients. If they discover a family history of familial hypercholesterolemia or premature cardiovascular disease, then certainly do testing. Do high-risk testing. Alternatively, if an adult clinician has a patient with known familial hypercholesterolemia with premature cardiovascular disease, they should make sure they recommend testing for that patient's children and other close relatives. My takeaway, and I hear about your takeaway, you already said it, most cardiovascular disease comes in the middle LDL distribution, not in the extremes. And the good news is that in the United States, the LDLs have been decreasing in children and adolescents, probably because of reduction in trans fat in the food supply. It may not be crucial to universally screen lipids twice during childhood, 9 to 11, and then 17 to 21, as much as targeted screening for risk factors and a good cardiovascular history, and treating obesity and diabetes. And of course, on the other hand, insurances give us incentive to do this now. So there's a financial incentive to say you need to test this, that's a recommendation. But we should really lean on getting a good cardiovascular disease family history. I don't know about you. I still look at this and think it probably is a good idea to screen, high risk for everybody. But if they have no risk, to do it once before they leave us. And whether it's 9 to 11 or 17 to 21, and really stress that if it's normal, it doesn't mean, okay, bacon sandwiches every day. If it's high, LDL is a little bit high, it doesn't mean, oh, you're going to have a heart attack. And that's what it means by being in your medical home, so we can explain that. And big thing is promote lower dietary salt. July 16th and 18th, shameless plug at Hot Topics Pediatrics. So be there. A little nugget. Did you do the question of the week from Jim Stockman?
No, you've been encouraging me
really
to do
good.
it for years.
So
yes.
he did one in March of 2025 about lipoprotein A assays, and that this test remains unchanged after age 5. It's not a fasting test, independent of BMI and sex, and it is a distinct risk factor for future cardiovascular events. So if I have someone who has a big family history of a cardiovascular event, or if their lipids are really high, at some point I'm going to get a lipoprotein A. I think it can be helpful to decide even the timing of maybe starting statins. But hold the presses, Matt. Just this week, the new guidelines of the American College of Cardiology and American Heart Association, the adult heart people, came out, and one thing they said was every single human should have a lipoprotein A at some point. So I don't know if you've sent them much, but I feel better that I just get them once, don't need to follow it. But they also said, more importantly, that they are recommending everybody get their first lipid profile by age 19, no matter what their risk factors, and then every 5 years after that, and maybe even sooner if they have risk factors. And they said you should start statins starting at age 30 if your LDL is greater than 160. But they also affirmed screening at 9 to 11. So they went all in with the pediatric cardiologist and the AAP saying, yes, we affirm you should do those, and then you should get them more as an adult. They also mentioned the PREVENT, PREVENT risk calculator, which my primary care person will talk about it. I don't really know what that is. Do you? So It's a way to look at risk, decide. I think we're both on statins.
Yes.
Okay, so low dose, but we are.
Yep.
It also mentioned calcium scores, that they should be used more. Have you done that?
I have not.
Get that.
I wanted to ask.
Okay, I did get that. It wasn't charged by insurance. It was $100, but you want it to be zero. Yep. But you should get that, Maddie. Okay. One of the main people in this was quoted was a Dr. Neil Stone from Northwestern Cardiology. He's a big deal in Northwestern Cardiology, and I was thinking, he was there when I was there. He must be like 1 billion years old. Well, he's in his, I don't want to be ageist, he's in his lower 80s, I think. But he's still working, brilliant guy.
Probably because he's been watching all these things,
Maybe,
right?
more than I. All right, I think we're going to take a break. we are back. Well, just me for a couple minutes. Right after we taped this ADHD episode, 2 really interesting studies came out concerning ADHD that I wanted to mention, since who knows when we'll ever cover this again. First published in JAMA Psychiatry out of China and Australia, analyzed 1,154 three-dimensional T1-weighted structural MRI scans of children and adolescents with ADHD. And the findings aligned with 3 different types of ADHD. One is the predominantly inattentive type, and the second, predominantly hyperactive impulsive type, both of which we are used to breaking down when we think about ADHD. But then there was a third, more severe subtype marked by emotional dysregulation and difficulty managing and responding to emotions. This more extreme subtype showed the most extensive changes across the brain, a total of 45 abnormal areas, versus 26 for the other 2 subgroups. So it doesn't seem to be just more severe ADHD, but something meaningfully different. There seems to be overlap with the conditions that have been described as disruptive mood dysregulation disorder and oppositional defiance disorder, which are terms we don't love to use because they can be a bit stigmatizing and not always describe what we are seeing. And this certainly reminds me of the recent studies we talked about on autism, which seems to divide into 4 distinct types. One with more anxiety, depression, ADHD, and seemingly being turned on genetically at later ages after age 6. So what could this mean in ADHD future diagnosis and treatment? Maybe we will be better able to tailor treatments to the type of ADHD. Which kids might respond more to behavioral and rewards, and which may respond better to medications, and which specific medications might be best. And speaking of medications, the other recent study in the journal Cell on brain imaging of nearly 12,000 children with functional MRIs showed that traditional stimulant ADHD medications, like we're talking about mostly here today, act on arousal and reward systems and not attention centers, and can change the connectivity in brain regions governing wakefulness and reward anticipation. So yes, they don't really seem to have an effect on the parts of the brain that control attention. Some have mentioned that this may partially explain the paradox we've always had when we give stimulants to a child who's already very hyperactive, and it seems to paradoxically calm them down. Some conjecture that these stimulant medications do not blindly enhance the ability to pay attention, but rather increase the child's willingness to participate when they're kind of bored and not engaged. And we all know, as we mentioned here, that ADHD can be a superpower. When they're really engaged, they have incredible attention, but shifting to certain tasks that don't engage them is really, really difficult. They also mention that stimulants also may be treating chronic exhaustion and sleep deprivation more than boosting attention. But as we know, long term, if you don't address the chronic sleep issues, it will not be good for your brain. There is a caution here. Other neurologists feel that relying on resting state functional MRI doesn't really capture the attention circuits well. So with both of these studies, there's just a lot of information coming out about ADHD and how treatments may work. Hopefully this will lead to better and more accurate diagnoses and treatment plans. Okay, now back to our show. We are back. Okay, boys and girls, we're going to cover ADHD psychopharmacology, tips from Dr. Stephanie Hartzell, a pediatric psychiatrist extraordinaire from Providence, Rhode Island, from her Hot Topics last year, and mostly talk about what we do in our own practice. So again, sign up for Hot Topics July 16th to 18th at Glen Floridian. Again, when we talk about this, any errors that we make are ours, not Dr. Hartzell. And we'll mostly be talking about medications and different styles of prescribing ADHD. But I think Matt and I would agree that it's particularly challenging if you do decide to treat younger children, right? 6, 5, even 4. Mm-hmm. And I'm going to make another shameless plug. The 57th annual ROI Warren Seminar, my 29th year running it because I'm old, Wednesday, November 11th at Nemours Children's Lecture Hall. It kicks off with a great grand rounds on ARFID, and then a day of tips and pearls, only for in person, and with mostly Nemours Peds alumni, including our very own Dr. Brittany Perry and Dr. Megan Harrison, who are going to talk on pediatric psychopharmacology for the very young children. And then there's a very fun alumni reception at the end at 4 p.m. And Matt, I was just showing him when I was program director, the pictures of everybody. He was in my first class.
Oh, boy.
And I screwed him up.
That's what happened. That's right.
I screwed him up. 1992.
I've recovered.
93. He's recovered. Are you going to go? You're going to try to go to this alumni?
I put it on my calendar.
November
today.
11th.
Yes.
Great.
All right. So the diagnosis of ADHD has increased over the years, like some of the other things, once we start to understand them better, to about 1 in 9. Over 7 million kids in the U.S. between the ages of 3 to 17 are considered to have ADHD. So it can be a positive superpower in kids who can hyperfocus. And oftentimes, it leads them to achieve great things in the video game world.
They can be so good at video games, right?
Yeah, but then it makes, for instance, 10 minutes of Spanish homework untenable and torturous for them. Yeah, right. So, but, many of these kids have a ton of energy, and they just need to get through middle school and high school in order to, thrive.
Yes, and I want to just add, the incidence may be increasing due to social media. A paper in Pediatric Open Science that came out this week on social media use showed increased inattention in young people over 4 years due to social media.
Not a surprise.
Not a surprise, but hope. Also this past month, 2 huge lawsuits got a jury decision against Meta and YouTube, found liable for harm from their services, their addictive services. One in LA, one in New Mexico. They found in New Mexico that Meta intentionally harmed children's health, and with their endless scroll and their autoplay. Some people are thinking that these are the beginning of suits almost like big tobacco, when we finally said this is harmful and you need to do more. So stay tuned, but a little hope that they're going to have to change their algorithms because they're killing kids, literally.
Oh, it just there's I think really growing evidence that it changes the architecture of the brain.
Yep.
It changes the neurophysiology.
Yeah,
right?
and there's the age limits don't work. They need to do something.
Yes. So Dr. Hartzell acknowledged that the Academy of Pediatrics ADHD guidelines for younger children talk about first-line psychological support as being the primary focus for ADHD in those kids. But this is really hard to find,
Right.
Super hard to find in the community. Oftentimes people who do a really great job with other aspects of the way that young kids' brains work don't necessarily specialize in this.
Right.
One thing that I think is worth mentioning is that a good sleep history is always important for so much that we do in pediatrics.
We're all about sleep.
But this ADHD issue definitely needs a little bit exploring on the sleep side from a practitioner's standpoint. Snoring, unrestful sleep. One can even look at the way that the mouth is set up with that Mellon-Potty score of how the posterior tongue and the pharynx, et cetera. All these things come together to potentially be interrupting good sleep. So there's an awful lot of things to be considered. There are an awful lot of things to be considered with ADHD aside from just the diagnosis. Also look at how they're growing. Also look at family stressors. This is a very complicated diagnosis.
Is. And as we've said, the sleep, like when they go to bed, when they get up, the weekends, the whole sleeping in on the weekends, and their dead boy walking or dead girl walking
going
Monday,
back to
Tuesday,
our
Wednesday,
very first
all
podcast.
Our sleep stuff. You got to ask that. You got to ask that every single time. So Dr. Hartzell mentioned about scales like Connors and Vanderbilt's, and we've talked about it before. Those are screens. Those don't make a diagnosis, okay? No. And if you want to make a certain diagnosis as a parent, you know how to answer those questions. But they are screens. But she did say something I don't think I completely agree with. She said that neuropsych testing, psychoed testing can be helpful, but sometimes can be a barrier to timely care. And the diagnosis is the clinical one. And she doesn't always push for these psychoeds, but respectfully, I would disagree. It's sometimes challenging to get them, can be expensive, but if you can get them, it's crucial that you make sure there's no concomitant learning issues, processing issues. Can even occur if a child's getting decent grades. I always push to try to get these on top of just a Vanderbilt and a Connors. It's nice to have a Basque too, but it's nice to have a full educational evaluation, and it depends on the state.
Right.
I've got to say, Pennsylvania, their schools are better funded. They do a better job. I don't know if you found that. We're both near the border in Delaware and Pennsylvania.
I kind of fall between the two. I leaning a little bit on Dr. Hartzell's side. I just think oftentimes it's not it's a great idea. It's not always practical, and that can certainly then postpone care.
Right.
And I struggle with the fact that many times, at least quality, psychoed tests aren't readily available for the families that we take care of, and you hate to have something that was done perhaps not optimally try to help you make decisions when you are dubious about the evidence, right?
Right. And so I don't disagree with that, and sometimes I can't get it.
Yeah.
But I just want to make sure that overlapping diagnoses like anxiety, OCD, autism, mood issues, family trauma, substance use, and again, that's subtle learning and processing problems. So I'll get off my soapbox, but
no,
it's
I'm going
hard
to stay
for
on your
us.
soapbox for just a second, because I think that all kids should have neuropsych exams done periodically throughout their childhood.
Yes.
Instead, we're too busy prepping them for tests that then are a measure of how their schools get funded.
Right.
Let's instead decide how they learn.
Right,
and
how the
put them in a
individual child learns. But you know what? We've said this before. If they did it, they wouldn't, by law, they wouldn't be able to accommodate all these kids. And so that's the conundrum.
Which is a shame, right?
It's a real
The squeaky
shame.
wheel gets the grease.
Yeah.
Everybody else kind of gets put on hold.
It's a real shame.
Yep. So other things that can be looked at, just to be complete, is you can see if there's any evidence of anemia or even diminished iron stores, and then consequently replenish them. Dr. Hartzell also mentioned the role of executive function coaching, which, again, to me, is a very reasonable thing to do. There are folks out there who do a great job with this, but for a lot of families, just even economically, that can be prohibitive.
I have a whole list, but I say ask how much it's going to be.
Sure.
But sometimes, especially with the high school, college kids that are really struggling, just 1 or 2 visits can be helpful.
And it seems to me that an awful lot of parents are aware now that their children may be, for lack of a better term, different in some way, whether it be with behaviors or the way that they approach the world. And the thing that they seem to be most familiar with is this diagnosis of ADHD. So many folks will come in and see Rob or myself and say, I think my child has ADHD. But what we're not looking at are the many other things out there that can change the way a child processes the world and acts. And those include things like, again, not to be an old drum here, but anxiety, depression, anorexia, PTSD. I mean, even in some of the older kids, bipolar disease. All these things can look like ADHD does, but it's a much more complex means by which we need to approach these kids, because oftentimes ADHD, although it's the hot button phrase, is not the issue.
Right.
So there's a lot of concern about us over-medicating kids, and there's real data that untreated kids with ADHD actually have a much higher rate of the other mental health issues, some of which I just mentioned, and of dropping out of school.
Right, the risk of not treating them
exactly,
which
is high. So medication treatment with stimulants, which is one of the drug classes that we talk about, has been shown to be more effective than the non-stimulants, which is the other drug class. And 80% of kids respond to stimulants, whereas only 30 to 40% of kids respond to non-stimulants. And Dr. Hartzell's usual first-line meds are the methylphenidates, which we've talked about in the past, which are better tolerated and pose less risk in terms of things like mania. But a lot of what we do with this is, unfortunately, trial and error. So people oftentimes will wonder about genetic testing. This is certainly another topic that we've talked about a little bit in the past. And genetic testing is not a silver bullet.
Yeah, the whole pharmacogenetic issues and tests, they may work somewhat for mood and anxiety,
right?
But everything ends up in the same column.
Yes, it does.
And they're just looking. They're not looking at efficacy. They're just looking at reducing risks of side effects.
Yes.
So it's not like you're going to get a test saying, okay, this drug's going to help you the most.
This one will work. Right?
So it's a lot of money, and usually it's not covered by insurance.
And that also confuses our families, because they think, well, can't we just order a test? Like my cousin had a test that said blah blah blah, and it's just not that straightforward.
Right. So she went over a little bit side effects, and we all know if you do this that the number one side effect by far is appetite suppression, especially at lunch. She mentioned she sometimes uses an appetite stimulant at bedtime, probably like generic cyproheptadine, generic Periactin. I think both of us, Matt, really shy away from giving a medication to help a side effect of another medication, if at all possible.
True. I mean, not to say that we never do this, but we go to great lengths to not fix one medicine's side effects with another medicine.
And then you get polypharmacy.
Yes.
Now, also this can cause difficulty falling asleep, headache, hypertension, tics, movements. It's thought that this doesn't cause them as much as uncover them in someone who might have had them. And usually it can get better or you get off it. Also can give you irritability and change your personality. You have to mention the black box warning for suicidality, mood anxiety, which I do, but also know that if it works, often it's the opposite. They're happier.
Absolutely.
They're happier. And also, this is something I didn't mention 20 years ago, but I certainly do now. The potential of loss of 0.5 to 1 to 1.5 inches of height, especially if you start this early in a growing child. And I think that's real.
So it's interesting because this pendulum has swung both ways on the whole height issue, right? So we talk about height velocity in children, and certainly there are times of their lives when they grow more quickly, kind of pre-adolescent and adolescent. But for the most part, most kids will gain, the average kid will usually gain about 2 inches a year, kind of in mid-childhood. And what Rob was just alluding to is that when we were originally trained, it was thought that there could be a diminution in the height velocity along with these medicines, but that was a reversible one. So if we stopped the medicine, they would go back to their growth
as long
curve.
as they were eating enough and they weren't losing weight.
Exactly. Whereas more recent evidence shows that, yes, they were right the first time. There can be a diminution in growth velocity, over the span of a lifetime, and that's not nothing, right? I mean, that's a good inch or so.
That's almost an inch of loss of height. So
exactly.
They need to know that. And also, if the medication works well, but the child says, "I don't like the way I feel," then we got to stop it, reduce it, change it, because that is not something that we want to continue doing if the child says, "I just don't like the way I feel on it." She often starts with a short-acting methylphenidate, titrated twice a day, probably some kind of Ritalin generic twice a day, and then goes to long-acting. But honestly, Matt, I rarely do that. I usually start with a younger child. I start with generic Focalin XR, so dexmethylphenidate, ER. I start with 5 milligrams. I went to a talk and they had these papers on that, and that's a nice medication because you can open up and slurp it in applesauce. You don't chew it, but you don't have to swallow it. And I do 1 pill for 5 days. I give them a handout on this, and if they're not showing any side effects and maybe it's working a little bit, I have them go to 2 for 5 days, and then if that isn't working optimally and there's no significant side effects, I go up to 3. So they're going to finish those 30 pills. It's a controlled substance, so we do one time. They can finish those in 2 weeks. They're going to call me. But this way I can have a ramp up of the medications. I only do it while they're in school. During those 2 weeks, if they're home during the weekend, that's fine because I want them to see how it's working at home. And then when they call me, they might say, "You know what? I went to 15 too much, 10's perfect," or none of them worked, or side effects, even the low dose, and we need to try something different. So I don't know if you do something like that. I do the same thing with generic Concerta, methylphenidate, ER, which comes in 18. So I go 18, then 236, then 354. If 36 is too much, 18 is not enough, I can a 27.
Right.
So I kind of find this over 2 weeks. You have to swallow generic Concerta, so you can't chew it, and you can't put it in liquid.
Right. So, no, I mean, I do something similar. It's probably not as kind of, protocol driven as yours. There for a while, we were having a very difficult time obtaining any of these medications. Right. And so I think that has kind of veered us off of our, okay, this is the way we always do it type of a path. But yours is a very reasonable way to go. I do it slightly differently. I agree with you in terms of starting with the long acting more often than not, unless it's a really young kid or unless the family themselves is very leery about, the whole experience. Then oftentimes we'll start with the short acting and go on beyond that.
But I feel like the generic Focalin XR is intermediate.
Yes. Oh no,
it'll last through the afternoon. It's not as long as Concerta,
right?
But they don't have to go to the nurse at lunch,
Sure.
and I try to avoid that.
Yeah, we really do try to avoid that, and unfortunately, it's still quite a thing,
right?
And there is some stigma to that, right?
Right.
For the amphetamine stimulants, so there are the methylphenidates, so there's methylphenidate and dexmethylphenidate. For the amphetamine stimulants, Dr. Hartzell really does like the generic Vyvanse, which can also now come in chewables. So essentially the original version was a powder inside of a capsule that the capsule could be pulled apart and then put into a liquid. But the chewables are just as good an idea. And this medication is nice because it is not a source of kids abusing it.
It's a prodrug. It's a
prodrug. Unlike Adderall, which I think both of us are loath to use, which is highly abused by both high school and college students and some adults, Vyvanse is something that you can't get an immediate high off of. And so people leave it alone in that context.
Do you remember when there was a shortage and people couldn't get their Concerta, I can't get it.
Yes.
I can't get my Vyvanse. But then when they couldn't get their Adderall, they're like screaming at us, "We can't get our Adderall." I think that said something about the addictiveness of both the short acting. So sometimes older teens get very disappointed in college. Like, I'm going to go down, treat them like I'm saying I'm not going to start with that.
Yeah.
And that's what they want. So that always tells me something right there. So Maddie, I thought we'd spend the rest of this time just going over the list. We have this beautiful laminated list from the Cohen Children's Center. You can get this for free. Go online. It's so nice to have this. It gives like every possible medication. So I'm going to start with the methylphenidates. I'm going to start with something I don't use anymore. Remember Daytrana patches with methylphenidate. I used to use these when they came out. Did you?
Not much.
They caused some skin problems and irritation. I think that's what did it, but you didn't have to swallow it.
Right.
I always thought there was going to be some kind of a Judd Apatow movie where they'd have like somebody with like
somebody who's covered in them.
Patches on them, right? But Steve Carell, did not. So then we get back to the methylphenidate long-acting orals. We mentioned about Concerta, generic Concerta. We both use that?
Yes.
Okay. We both use the generic Focalin XR.
Yep.
Yes. And Contempla, have you ever used that?
One of my co-providers uses a lot of Contempla.
It's great flavored, but I've never used that.
Yeah.
Abtensio XR, I think I used it once. It's more of a biphasic, so you get a little more oomph in the morning. Quilvant, the liquid.
Again, some of my fellow providers use it. I'm not facile enough to use it at this point.
Right. The Quilla Chews I used to use. I haven't done it as much. And then the Ritalin LAs, again, biphasic 50-50.
Yes.
I haven't used those in a while. The Metadates, CD and ER, they often are covered by insurance.
Right.
And generically.
Right. So a lot of these, just explain to the folks listening if they're not already familiar with these things. A lot of the long-acting methylphenidates will indicate that they give a certain amount immediately, so upfront, and then another percentage as the day goes by. And so, for instance, Ritalin LA, or now methylphenidate LA, is a 50-50, as Rob said. So 50% up front, the other 50 kind of throughout the rest of the day. From at least some of the things that I've read, a lot of these things are not terribly accurate in terms of how they're released. So some of the other methylphenidate long-acting medications are 40-60, and 30-70, and for those, apparently that release and that timing is not nearly as specific as the manufacturers report it to be. So oftentimes we're stuck, as Rob said, by what's covered by your insurance.
Right, exactly. And then there is the prodrug. We mentioned prodrug, which is Vyvanse for the methamphetamines. The prodrug in the methylphenidates is Astarsis, which is a little bit newer, and you can put it in water. You don't have to swallow that pill, and it really works well very quickly. So I don't know about you, but I have
a couple
used
patients.
that more.
Yep.
And that's something that's very interesting. And then there's Jornay PM, the only one that's given at night. It's absorbed through your colon.
Yep.
And I got to say, the best thing about this one, two best things. One is efficacy upon awakening.
Yes.
It works when you wake up. And the second thing is less GI effects. So as someone who's losing weight and such, I think it's a really good model. And I'm sure there'll be competitors out there, but it's the only one.
Yeah. I've had a few kids, I've had quite a few kids do well on this, quite a few, not a ton,
and
but
hard to get it covered.
Yeah,
right?
hard to get it covered.
A lot of hoops to go through, but you can usually get through those hoops.
And for some kids, they find themselves actually, the parents have reported to me that they wake up an hour or so earlier than they would have,
right? So
which is problematic. And then you just work your way back.
But you also got to remember to give it at night. So that also is a challenge. And then there's a few here, the short acting, the regular dexmethylphenidate, Focalin, the regular Ritalin, methylene, chewable solution. Again, I think those on the short acting will be for the younger kids. But then there's also giving a second dose.
Yes.
So I used to do that more. I don't usually do it as much. And if I do it often, instead of taking the second dose in the afternoon, especially college kids, they'll have that one, and they'll take it on a Saturday and Sunday if they slept in and forgot to take meds, and they have 3 or 4 hours of work.
Right.
So I don't have that many routinely where I'm taking one long-acting in the morning, then a second one in the afternoon. But that is a possibility. How about
For
you?
sure. So yeah, I mean, it's not uncommon for some of the children that I treat to need a smaller dose, whether that be midday or in the afternoon, to facilitate the initial effect of the first one as it starts to dissipate in their bodies. So, and I'll even have people who, the children are so distractible that they have a hard time participating in a sport. And so on a weekend, a short-acting dose before their baseball game, oftentimes helps to increase their involvement in something that's good for them.
And you know what? And that's okay. It is a performance-enhancing drug. We're both sports guys, right? Mm-hmm. It is. But you got if you're diagnosed, you got to do it the right way. If you do it like Chooch did, Carlos Ruiz, and you start using Adderall without a doctor, you get a 50-day suspension. Right. Yes. We'll never forget that. All right. So the amphetamine formulations. On this list, long-acting Dynavil XR, 2 different Dynavil XRs. I don't have much experience with them.
Same.
Deus, I've had some experience with them for 13 and above, and for adults. You?
Yeah, same. Okay. I mean, not much experience. A little bit.
Then there Adzenys, not much experience with them.
None.
Adderall XR. So we both said we don't love using it in a lot of ways. We worry about that it's addictive qualities, but have I used it? Absolutely.
Same.
And sometimes it works really
well.
Try
not to, but sometimes that's really the best route.
And then there's dexedrine spansules, which I haven't used that much.
I used them only rarely, and that was at the beginning of my career. So.
Right. There is transdermal. I didn't really know this. Zellstrime, D-amphetamine patches.
I'll bet they're good. They're big down the Bowery.
No, I've never used them. All right, then there's a prodrug. We mentioned Vyvanse already. Capsules and chewables. That's one of our mainstays. I think it's a good medication. And then there's short-acting amphetamines. Regular Adderall we mentioned. Zenzetti, down to 3 to 5-year-olds. So 2 of these have indications for 3 to 5. Evykio and Zenzetti. So
again,
that is something.
I don't use them.
Right, although I don't see any other medications on this list that are indications that young. So maybe when we go to our psychopharmacology with Dr. Harrison and Perry, she'll be mentioning that in November 11th. And then there's the non-stimulant class. So let's take a few moments, okay? I think we both use the non-stimulant class.
We do.
Yes? All right. So the alpha-2 agonists like guanfacine, approved for age 6 and above, 10X or Intuniv, or clonidine, Cataprest, or Capve. Dr. Hartzell mentioned she will use these in combination, especially if there's no sleep difficulties, but they do have sedation side effects.
Right.
So often
she'll use them if there are no sleep issues, because sometimes I find that they enhance activity, that they benefit for ADHD, but also that they enhance their sleep.
Again, it can make you sleepy. So maybe if they're having trouble sleeping,
you can
get a side
kill
benefit.
2 birds with one
stone. Exactly. And there's some of these medications are used for hypertension, so there's a low blood pressure risk and trying to have a lot of fluid. There is a warning about suicidal ideation with some of these medications, and you have to take it every day.
And it takes much longer.
You don't get
to work.
With all these, it
3 to 5 weeks.
It takes much longer.
Very
the nice
similar
thing about
SSRIs.
Stimulants, we'll know in a week or so. We'll get some idea how it's working. Guanfacine also has helped with tics. So I've had kids get tics on a stimulant, and I go to the guanfacine trying to help their.
And the same with clonidine. Remember, that's how you and I learned. The original med for tics
is clonidine. Right. And then there's the NRIs like Strattera, atomoxetine, Qelbree, Velexidine for 6 and above. They both can interact with things, SSRIs like fluoxetine and dextromethorphan for serotonin syndrome, and can have side effects like priapism, constipation, fatigue, avoid if there's any cardiac issues. But, I've used them. The nice thing about Strattera is it also helps for anxiety, right? So the side benefit.
Yep, I have occasionally used it in that instance. Yep.
And then there's bupropion, generic Wellbutrin. It's nice. It's kind of 2 doses I think of, either 150 XL or 300 XL, both for mood, anxiety, and for ADHD. It can increase insomnia, sometimes anxiety. There's a black box warning for suicidality. You don't want to use it with bipolar, but have you used Wellbutrin?
I have not used it for ADHD. I have used it for kids, for other mental health issues.
I have also, and if I knew they have some ADHD, I'm more likely to use it.
Sure.
So it's certainly not my first or second line for ADHD. And then wrapping up, there's some non-pharmacologic treatments been approved, like the Monarch E trigeminal nerve stimulator for ages 7 to 12, given overnight. Have you have any experience with that?
I do not. I have not.
Yeah. They do in different stimulants also for mood and depression. There's also that video game.
Yeah, we talked
Endeavor
about that a long
RX.
time
We
ago.
did.
I've not seen any
8-17.
follow-up studies on its efficacy, but all these things are kind of, I think, like so many other things we do, Rob, it depends on what works, for which individual, right?
Exactly. All right. So we're wrapping up. So this one really was shorter than usual, and I hope this will be the model going forward. But we talked last time about the Bobby Darin, Jonathan Groff, Just in Time.
Oh, yes.
And we talked about, Mac the Knife. But what was his first hit? What was the one that got him on the charts, that got him going?
It was
Ready?
classic early bubblegum pop, right?
And let's hit it. Ready? 1, 2. Splish, splash, I was taking a bath. Long about a Saturday night. Rub-a-dub, just relaxing in the tub. Thinking everything was all right. Well, I stepped out the tub, put my feet on the floor.
I wrapped the towel around me and I opened the door. And then a
splish splash,
I jumped back in the bath. Well, how was I to know there was a party going on? There was a splishing and a splashing. Reeling with the feeling. A moving and a grooving. A rocking and a rolling.
Bing,
Bing,
bang,
bang,
I saw the whole gang
dancing on my living room rug.
All right, say goodnight, Maddie.
Flip flop. Oh, man, I was getting into that one. All right. Good night, folks.
Good night, Moon. Podcast Pediatricians Productions. All rights reserved.